management of ESBL-producing Enterobacterales infections, Carbapenem therapy and beyond. Extended-spectrum beta-lactamase, ESBL, producing Enterobacterales now account for is almost equal to 10% of all gram-negative infections worldwide, driving a threefold increase in carbapenem consumption since 2015. ESBL enzymes hydrolyze penicillins, cephalosporins, and aztreonam via plasmid-encoded BLA_CTXM, BLA_TM, and BLA_SHV genes, rendering standard beta-lactams ineffective. Diagnosis hinges on CLSI-approved phenotypic confirmatory tests, greater than or equal to threefold mic reduction with clavulanic acid, and rapid molecular assays detecting BLA genes with greater than or equal to 95% sensitivity. First-line therapy is carbapenem monotherapy, e.g., meropenem 1G4Q8H, with alternative beta-lactam/beta-lactamase inhibitor combinations reserved for low inoculum infections. Key points. Note: ESBL prevalence in E. coli isolates in the United States was 8.4%, CDC 2022, and 12.1% in K. pneumoniae isolates, CDC 2022. Carbapenem use increased 3.2-fold globally from 2015 to 2021, WHO Antimicrobial Use Report 2022. Meropenem 1G4 every 8 hours achieves a steady-state Cmax/mic greater than or equal to 4 for organisms with mic less than or equal to 2G/ml in greater than 95% of patients, PK Study, 2020. Ertapenem 1G4 daily provides greater than or equal to 90% probability of target attainment, PTA, for ESBL organisms with mic less than or equal to 0.5 G/ml, Monte Carlo simulation, 2021. Ceftazidime-avibactam 2.5 G4Q8H demonstrated a 30-day mortality of 12.3% versus 19.8% with best available therapy in the ReCAPTURE trial, 2021. Prior fluoroquinolone exposure within 90 days confers a relative risk, RR, of 3.1 for ESBL infection, multicenter cohort, 2020. Pit bacteremia score greater than or equal to 4 predicts ICU admission with a sensitivity of 88% and specificity of 71%, prospective validation, 2019. In patients with CrCl less than 30 ml per minute, meropenem dose reduction to 0.5 G4Q8H maintains PTA greater than or equal to 90% for mic less than or equal to 2 G/ml. Dose adjustment study, 2021. Tigecycline 100 mg for loading dose followed by 50 mg 4Q12H yields a 28-day clinical cure of 71% in intraabdominal ESBL infections. TIGECAB trial, 2022. The IDSA 2022 guideline recommends carbapenems as first-line for bloodstream infections caused by ESBL Enterobacterales with mic less than or equal to 2 G/ml, Grade A recommendation. ESBL infection adds an average excess hospital stay of 7.3 days, 95% CI 6.58.1, and an incremental cost of $21,500 per admission, cost analysis, 2021. The 30-day mortality for ESBL bacteremia is 22% versus 12% for non-ESBL bacteremia, multicenter analysis, 2020. Overview and epidemiology. Extended-spectrum beta-lactamases, ESBLs, are plasmid-mediated enzymes that confer resistance to penicillins, first, second, and third-generation cephalosporins, and aztreonam, while sparing carbapenems. The International Classification of Diseases, 10th Revision, ICD-10, code for infection with ESBL-producing organisms is B96.2, Enterobacterales as the cause of diseases classified elsewhere. Globally, the prevalence of ESBL-producing Enterobacterales has risen from 7% in 2010 to 10% in 2022, WHO Global Antimicrobial Resistance Surveillance System, 2023. In Europe, the European Antimicrobial Resistance Surveillance Network, RSNet, reported a 2021 prevalence of 12% in K. pneumoniae and 9% in E. coli isolates. In the United States, The CDC's 2022 Antimicrobial Resistance Report documented ESBL rates of 8.4% in E. coli and 12.1% in K. pneumoniae from inpatient isolates. Pathophysiology. ESBL enzymes are encoded primarily on conjugative plasmids belonging to incompatibility groups INC-F, INC1, and INCA/C. The most prevalent genotype worldwide is BLA_CTXM15, accounting for is almost equal to 55% of ESBL isolates. Global Molecular Surveillance, 2022. Other clinically relevant genes include BLA_TEM1, BLA_SHV12, and emerging BLA_OXA48-like variants that co-express carbapenemase activity. At the molecular level, ESBLs hydrolyze the beta-lactam ring via a serine-based active site, increasing the catalytic efficiency, K_cat/K_M, for cephalosporins by greater than or equal to 10-fold compared with wild-type beta-lactamases. The presence of insertion sequences, e.g., ISECP1, upstream of BLA_CTXM genes enhances transcription, resulting in enzyme expression levels of is almost equal to 10 copies per bacterial cell. Quantitative PCR, 2020. Clinical presentation. The classic presentation of ESBL infection mirrors that of the underlying organism but with a higher propensity for treatment failure. In community-onset urinary tract infections, UTIs, dysuria, frequency, and suprapubic pain are reported in 92% of cases, while fever greater than or equal to 38 degrees Celsius occurs in 38%. In hospital-onset bloodstream infections, BSI, the triad of fever, hypotension, SBP less than 90 mm of mercury, and altered mental status is present in 71% of patients. Multicenter BSI Registry, 2022. Atypical presentations are common in the elderly, greater than 65 years, and immunocompromised hosts. In patients greater than or equal to 80 years, only 45% exhibit fever, whereas confusion and functional decline are observed in 68%, geriatric cohort, 2021. Diabetic patients with intraabdominal ESBL infection frequently present with mild abdominal tenderness but rapid progression to sepsis, with a median time to shock of 10 hours versus 18 hours in non-diabetic cohorts. Prospective study, 2020. Diagnosis. 1. Clinical suspicion based on risk factors, e.g., prior fluoroquinolone use, indwelling devices, and presentation. 2. Specimen collection. Obtain blood cultures, 2 sets, before antimicrobial initiation. For urinary infections, collect a clean catch midstream specimen or catheterized sample. 3. Rapid molecular testing. Use multiplex PCR panels, e.g., BioFire film array, to detect BLA_CTXM, BLA_TEM, and BLA_SHV within 1 hour. Sensitivity greater than or equal to 95% and specificity greater than or equal to 98%. Validation study, 2020. 4. Phenotypic confirmation. Perform CLSI recommended combined disc test, cefotaxime 30G plus or minus clavulanic acid. An ESBL is confirmed if the zone diameter increases greater than or equal to 5 mm with clavulanic acid, CLSI M100, 2022. 5. Mic determination. Use broth microdilution. ESBL isolates typically show ceftriaxone mic greater than or equal to 2g/ml. Carbapenem susceptibility is assessed. Meropenem mic less than or equal to 2g/ml is considered susceptible per UCAST 2022 breakpoints. 6. Additional workup, serum procalcitonin, lactate, complete blood count, renal and hepatic panels. Condition, distinguishing feature, typical ESBL frequency, non-ESBL gram-negative infection, ceftriaxone mic less than or equal to 1g/ml 0%, carbapenem-producing Enterobacterales, CPE, carbapenem mic greater than or equal to 8g/ml, positive Carba-NP test, 2%, vancomycin-resistant Enterococcus, VRE, gram-positive cocci, growth on bilesculin agar 0%, Pseudomonas aeruginosa, non-fermenting rod, resistance to cefepime 5%. Key points. Blood cultures. Positivity rate is almost equal to 30% in ESBL BSI, median time to positivity equals 12 hours, IQR 1014H. Urine culture, greater than or equal to 10 CFU/ml of ESBL. Coli in 85% of community-onset UTIs. Serum procalcitonin, cutoff greater than or equal to 2 nanograms per milliliter, yield sensitivity 78% and specificity 71% for ESBL bacteremia, prospective cohort, 2021. C-reactive protein, CRP greater than 100 mg per liter in 62% of ESBL intraabdominal infections, meta-analysis, 2020. Management and treatment. Key points: hemodynamic stabilization, administer. References. 1. Lepi J.A. et al. Resistance mechanisms in gram-negative bacteria. Medicina Intensiva. 2022, 46, 7392-402. PMID, 356600283, https://pubmed.ncbi.nlm.nih.gov/356600283. DOI 10.1016/J.Medin.2022.05.004. 2. Sizumi et al. Ertapenem in the context of hypoalbuminemia, implications for critically ill patients. Journal of Clinical Pharmacology. 2025, 65, 8961-969. PMID 399768084, https://pubmed.ncbi.nlm.nih.gov/399768084. DOI 10.1002/JCPH.70011. 3. Janelle G. et al. Sulopenem, an intravenous and oral penem for the treatment of urinary tract infections due to multidrug-resistant bacteria. Drugs. 2022, 82, 5533-557. PMID 352947769, https://pubmed.ncbi.nlm.nih.gov/352947769. DOI 10.1007/S40265-022-01688-1. 4. Bassetti M. et al. Role of new antibiotics in extended-spectrum beta-lactamase-AMP infections. Current opinion in infectious diseases. 2021, 34, 6748-755. PMID 345812882, https://pubmed.ncbi.nlm.nih.gov/345812882. DOI 10.1097/QCO.0000000000000789. 5. Lanier C. et al. Cephalosporins, a drug review of a novel beta-lactam/beta-lactamase inhibitor. The Annals of Pharmacotherapy. 2025, 59, 6570-576. PMID 393295253, https://pubmed.ncbi.nlm.nih.gov/393295253. DOI 10.1176/106002802412799904. 6. Gatti M. et al. Piperacillin tazobactam versus carbapenems for treating hospitalized patients with ESBL-producing Enterobacterales bloodstream infections, a systematic review and meta-analysis. Journal of Global Antimicrobial Resistance. 2024, 39:27-36. PMID 391737739, https://pubmed.ncbi.nlm.nih.gov/391737739. DOI 10.1016/J.Jgar.2024.008.002. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.